Morning, Chuck. Good to see you again.
All right, so are we live? All right, so we're welcoming the students in now, so we'll just kind of sit and say good
Just
morning.
to let you know, I invited both the third and the graduating fourth year students to participate today.
Great. What do we have from who do we have from Alabama?
I'm gonna check right now my email on Nate was sending those invitations, so I haven't checked on that. Give me 1 second. Let me see.
We invited D1 through D4 and the GPR. I don't know how many people from Minnesota are here today.
Okay. Well, the good news is we're going to record the session.
Great.
So this, at Roseman, they were requiring the students to watch this. So adding this to part of the curriculum, or at least an elective part of curriculum as a recording. It's like I said, this is yours. This webinar is yours for the schools. All right.
We appreciate that.
Are the other ones too? They were recorded and available,
They're
right?
all recorded. Yep. But this one's been updated and for the final version of we're talking about deep margin acquisition, the big cases, the big large composites that you're seeing on the clinic floor, right? And so that's what we're going to be talking about today. So why don't you go ahead and Carissa, if you can let me know when we've got the students up, when it seems like they're done populating. Morning, Jill.
Morning, how are you?
So one of the things that Augusto,
Yes.
one of the things that populated this was Dr. Mark Konings was out at University of Alabama, and he said, man, they were on the clinic floor, and I think it was you or I can't remember who asked, but said we need a 9mm matrix for these for DPK. So
It's probably Alabama.
Yeah, no, it's everywhere, and so we're actually building. I think I've got a picture. We're building another series of matrices as kind of secrets out, and we'll have a 9mm matrix for you. A 9mm matrix for everyday stuff, right?
Wow. Awesome.
Yeah. So that's exciting stuff.
Yesterday, somebody referenced rubber dam demonstration. Is that available?
I'm checking now.
Let's see.
Carissa's going to hop on right now and talk about the rubber dam video.
Hi everyone. So I will actually be sending up a follow-up email to all attendees, panelists, and it will include all the links, all the recordings, and any videos, relevant videos that we discussed in any of the webinars.
Okay, thank you.
Yeah, of course.
We talked about that yesterday, this has to start with the best fit rubber dam possible. And in dental schools, when they tell students you need to have a perfect rubber dam, it's not just because they're trying to be difficult. There's a reason why, is that if you're going to perform at this level and do these type of restorations, it has to start with a CLE rubber dam.
Yes, absolutely.
Yeah, and I think it's nice to support the schools and say, yeah, real dentists actually use rubber dams.
Right.
Okay? Real good dentists. All right. So are we populated, Carissa? Shall we go ahead and welcome everybody and get rolling? All right. Well, good morning, everyone from the Pacific Northwest. It's the crack of dawn here on Pacific time. So today is an installment that we're doing for the schools, and we want to invite welcome the three schools representatives that we have today. This started out with McGill and Dr. Taras Konanek and Dr. John Drummond, who were present at the Educator Summit that we had last year. And we will be having another Educator Summit this June, which will be virtual. So we'll be talking more about that. Then we invited University of Alabama. So we've got Dr. Augusto Robles. We're going to introduce him in a moment. And then we've got Dr. Sue Gross, who is representing the GPR program at Minnesota. So we've got schools from all over the planet here connected for this great experience. We have a we do have a Q&A or a chat room that people can ask questions. If you have questions, put them in the Q&A. And we've got representatives from the Bioclear Learning Center faculty members. We've got Dr. Joshua Solomon, who's a pediatric dentist. He'll say hello in a minute. Dr. Rafael Bustamante, who is on faculty track at the Learning Center, and he's up and works with University of Alberta. He's as a consultant, basically. So let me go ahead and go around the panel and let our faculty members say good morning. We'll start with Dr. Taras.
Yeah, good morning, everybody. So glad to again have this unification of the schools. David, thanks to Bioclear again for getting us all together. It's a really a first for us at McGill, being able to correspond and talk with other universities, and we really appreciate it. So good morning, everybody. Welcome.
Great. Dr. Augusto, am I pronouncing that right? Augusto?
Actually, it's very good pronunciation. Kudos to you. Yes, I am the head of operative dentistry at the University of Alabama at Birmingham, and it's just a pleasure to be here. It's a pleasure to be part of a team of people that are pushing this forward. Like it.
Pushing, I like that.
Yes, it's time.
It's time. Man, is it time. All right. Dr. Gross.
Good morning from Minneapolis. And if any of the students or GPR residents have questions of me, get a hold of me. And I wanted to say that this is one of the benefits maybe of having to stay in place and things, is that we all can get together like this. So great opportunity for learning. Thank you.
You bet. Dr. John Drummond.
Same idea, the staying in place and learning. We've done a lot of learning. It's not the same learning we used to do, but this is a wonderful way of learning. And I've opened this up to all the students in McGill this year, or for this weekend, this week's course. So we've got some of the third years and some of the graduating fourth years. So everyone is here, and we really appreciate the support we're getting from Bioclear. So thank you, David. And it is great to interact with all the other schools. Let's look forward to a great morning.
Wonderful. Dr. Bustamante.
Morning, everyone. Glad to be back.
All right.
Still warming up here in Edmonton.
Okay. Dr. Joshua Solomon.
Hi, good morning, everybody. My name is Joshua Solomon. I am adjunct faculty at the Learning Center. And I was just adding up the numbers, and I think Dr. Bustamante and I are 1,200 dentists in the last 2 weeks in 5 countries. It's early this morning, but I'm up because, we're really excited to be able to have a touch point with schools. And I really don't know if everyone understands, how fortunate that I feel, and all of us should feel, of, learning these techniques early on in education, because I can tell you this is by far the best dentistry that I've ever done or seen. And I would take pretty much any of my restorations at any time and take a photo and put them in a journal or put them online. And I don't say that not to be humble. It's just, that's the training that we have. And the more that everyone, learns, the faster you are, the more proficient you are. And this is a significant, improvement in how things were done for the last 100 years.
Great. We want to get rolling with the presentation, so I'm just going to wave at Charles Hudson. Chuck Hudson from 3M Scientific Affairs from 3M. Thank you so much for your support, for the research that you've done behind the Bioclear method. We can't do it without you. Jill Carroll here is the representative from Bioclear in Canada. She's working with the doctors and the schools in Canada. Thank you, Jill. We've got John Pittendray from Clinical Research Dental, part of the three-way team in Canada. We're so happy and we're so grateful for your support, because as we're implementing the Bioclear method into schools, we've got to find a way to get the stuff in there, right? So we're excited to do the implementation. Great. So we're going to go ahead and once again, go ahead and put questions in the chat room, or excuse me, Q&A. We've got questions in the Q&A. Dr. Bustamante and Dr. Joshua Solomon can be answering some of those as we go along. If it's a great question for the whole crew, we'll do that toward the wrap up. We plan to go for 2 hours. It's from 5:30 to 7:30 a.m. on the West Coast. And so let's go ahead and get rolling. So we go to share screen here, and we're gonna have a little bit of fun today. So The curriculum that we're sharing today is built and shared between our 4 learning centers. We have a learning center here in Tacoma, Washington, one in Solihull, Varberg, Sweden, and now in Cairo. So the curriculum, the lexicon, the procedures, everything that we do is the same. And so that way we're able to do research. This is the first time that we've standardized composite dentistry. The cavity preps, the whole Venn diagram is now completely standardized because it's chaos. And when we go to each school has a different idea on how to do that. And that's fine, but it's hard to move together to push forward without standardization of the curriculum. These are the Learning Center faculty. These are some of our hands-on instructors, and these are some of the folks in Canada that are doing hands-on instruction. We were working with the University of Montreal yesterday, and I want to thank Josh and Raph for that. So basically, this is our dental community. One of the things I keep putting this up, if you can go to YouTube and watch the summary of the Bioclear method, it's about 40 minutes. It wraps up the whole thing, anterior and posterior, talking about compression versus tension, and talking about how the composite in this Clark Class 1 and Clark Class 2, the polymerization shrinkage with low C factor actually lets the composite shrink around the tooth, put the tooth into compression. And so all of the things that were kind of fighting us to do composite, when you change the Venn diagram, now they all work together. Instead of working against the composite, we're working with the composite, but everything has to change. And today we're going to talk about one of the biggest disruptors for the schools and for private practice is that of deep caries management. Deep caries management is something that we have not been standardized. So these are the schools I've got listed over here. Every one of these schools are teaching selective caries retention. So today we're going to be talking about selective caries retention, but trying to standardize that process. All right. So what I'm going to do is I'm going to steal a couple of teeth from the Clark cavity preps, the Class 1, Class 2, Class 3, Class 4. This was a lecture that we gave yesterday for the school. So we're gonna pull a couple of these standardized preps out. But these are based on selective caries retention. So that's the lexicon that we've settled on. Selective caries retention. You could also call it selective caries removal, but really more purposefully selective caries retention. We don't want to be ashamed of the fact that we're letting the tooth heal the carious dentin naturally by providing a great restorative seal. We doing okay? Yep. Okay. So this is the calla lily preparation of the Clark Class 1. And this is what we're teaching now for moderate caries or replacing old amalgams. Dr. Taras, you've been teaching these Clark Class 1 cavity preparations and the Bioclear method now beginning at the school. How is that going?
It's going to be actually the first year that we're doing the posterior, David. We've been doing the anterior the last 4 years with the students. So we are really excited to actually get this in the lab this year, but unfortunately we couldn't do it. So we're moving forward with the posterior in the pre-clinic as of this year.
So one of the things about this Clark Class 1 is it has this incredibly large tooth restoration interface. So if we're going to actually be successful with selective caries retention, we have to maximize our external seal. So the neat thing is that selective caries retention and these Clark preps, because they have such an incredible external seal with so much surface area, they go hand in hand. You can't do selective caries retention without an incredible external seal. So this is the Clark Class 2, once again, with the radius walls that allow a maximum interface of the composite to the tooth with a low C factor. So we've been doing this now for a decade with incredible results. So, but at the end of the day, if we cannot have a good restorative seal, if we can't put the tooth into compression, if the tooth is flexing and it's uncomfortable, then the tooth is going to end up needing endodontic therapy. So these are key. So let's review what the modern occlusal cavity preparations are. Number one, a fissurotomy. We take the fissurotomy burr and remove the caries from the stain. We know that we can't seal over biofilm or caries. Number two, the calla lily, which we just showed. That's for moderate decay or for taking out an old restoration. The next size is a flattened calla lily, in some cases with endodontically treated teeth, or a very difficult tooth. We'll just shorten the cusp by 0.5 millimeter to allow the calla lily to save the tooth and seal the tooth from a leakage. But in a case where it's somewhat undermined, that's the step before doing the next one, which is a cuspal overlay. And a cuspal overlay, we shorten the cusp by 2 to 3 millimeters, bevel that, and then we can actually do a cuspal replacement with composite, but we need 2 to 3 millimeters of clearance for composite. Every restorative material has a clearance indicator. With gold, I need 1 millimeter. With zirconia, I need 1 to 2. With Emax Press, about 2 millimeters. With composite, I need 2 millimeters cuspal clearance. We can restore cusps routinely with cuspal splinting, but what we can't do is put composite in a great big Grand Canyon of a tooth and expect it not to break. Composite does not strengthen the tooth. Composite does not strengthen the tooth. Bonding does not strengthen the tooth. Engineering can protect the tooth. So what are the modern class 2 preps? We have an opportunistic class 2 where we come in from the side. So if we're doing one class 2, we can come in and remove a little decalcification or a little bit of cavitation on the side of a tooth without coming through the marginal ridge. That's called opportunistic. We can only do that when the other tooth is prepared. Next, the Clark Class 2, infinity edge, compression-based, enamel-driven, and then a lateral partial cuspal overlay where we overmold half of a cusp laterally when we have deep interproximal caries. I'm just going through these quickly because I wanted to make sure you understood that the Class 1 and Class 2, these are the cavity preparations. So let's go over one of these very quickly. So as we're building the syllabus for the schools, this is case-based cavity preparations. So we're only going to teach a cavity preparation today once you've seen an x-ray and you have an existing composite. So I know we had in school, we said this is what a onlay looks like and this is what an occlusal looks like. Today we're teaching case-based cavity preparation. So this is one of the teeth from the syllabus, and it happens to be a tooth on Dr. Pat Retzer, who is down at University of Pacific, all right? So what did we see preoperatively for this patient? The patient has a large MO composite that's been patched. The mesial buccal cusp has an incomplete fracture. I can see a mesial buccal incomplete fracture here. The patient is asymptomatic. In our study, this is important, 70% of all the cracked teeth were asymptomatic. So we have to understand that most of the cracked teeth in our adult patients, and a lot of those teeth are previously restored, are asymptomatic. So just because the patient is asymptomatic doesn't mean that the tooth is not cracked, okay? So I have to begin to routinely look at teeth and say this tooth is probably cracked even though it's asymptomatic. There has to be a new lexicon. So here we are preoperatively, so let's go through the sequence that we always use. The first thing we do on every single tooth is disclose. We put the disclosing solution on the tooth. There we see, it helps us to identify where the biofilm is, and we can also identify cracks in the tooth. So there we are. We pre-wedge every single time. The pre-wedge is part of the modern class 2. If we don't pre-wedge, we can't do the Bioclear method. If we don't pre-wedge, we can't do the Bioclear method because it pushes the soft tissue out of the way. And by the time you do your class 2, you've got 3 millimeters of composite tooth interface that used to be covered with gums. That protects your rubber dam. Instead of taking the burr in this way, we take the burr laterally. So now we're going to begin to do a calla lily while we're removing the composite. We don't just cut a Grand Canyon in the tooth anymore. The burr comes in at 45 degrees. That's a massive change. Taking the burr from here to here is like reinventing the world because we've been taking burrs in teeth like this for 200 years. So when I'm removing decay now, we take the burr laterally like this. We don't break the cavity wall anymore with a big burr. We break the cavity wall with this with these burrs, and these are the burrs from Comet. We're so appreciative that Comet is supporting our cavity preparations, and Comet is writing a tuition grant to send students from schools. So we'll talk about that. Students from schools to the Learning Center to have one of the students actually as a champion of Bioclear to help teach the others to come here to the Learning Center. So that's great. So this is this little Christmas tree burr that we use to actually break the cavity wall. We'll disc the neighboring tooth to optimize the contact. Once the cavity prep is finished being prepped, now we blast. We blast the outside and the inside. So now we blast after the cavity prep is done. Okay? Now we can see, now that we blasted, one of the benefits of blasting is look at the cracks. If you watch the video and back this up, you couldn't really see those cracks very well. Blasting lets those cracks just explode. And now we see that the palatal cusp has an incomplete fracture. The mesiobuccal cusp has an incomplete fracture. I'm going to do a calla lily on the palatal cusp and a cuspal overlay on the mesiobuccal cusp. That's the biofit matrix looking from a palatal view. There's the biofit matrix from a buccal view. And you know what I learned on this case? I'm still learning. I should have used a taller matrix. Would you agree, Josh, Raphael, Taras? If I would have used the 6.5 rather than the 5.5, I would have had a little bit easier time having enough mylar to form the cusp. Now, it was okay. It was fine. But we're beginning to use a little bit taller matrices sometimes if we want to restore the cusp. Okay. So that basically gives us our form. Here's the go, no go probe. We know we can go to 5 millimeters depth of cure in the interproximal, and this case was right around 5 millimeters, so we didn't necessarily have to put a gingival increment first. One of the biggest problems we have is excess layering. So this go, no go probe, and we want to make sure the schools have some of these, will help us determine what 5 millimeters is. Otherwise, it's almost impossible to guess. So you can use a periodontal probe. We like the go, no go probe, so let's make sure that the schools have this when you're using biofit, so we know what 5 millimeters is. So in this case, we don't have to layer on the interproximal, although we're kind of borderline here. So we're going to go ahead and etch to the edge of the matrix. This is what we call the flowable curb. This helps us to create containment when we injection mold. And if I needed to, I could have put a gingival increment here, bulk fill flowable, if I would have been deeper than 5 millimeters. We do the push-pull technique, which we'll show you in just a bit. Gives us a beautiful, robust contact. That's our little containment system, or the flowable curb. We injection mold, Rockstar polish, and that is compression-based restoration of the tooth. All of the cusps are splinted together. We have gentle primary anatomy. We don't put deep anatomy in a brittle material anymore, like a composite, because it can break. And so these are incredibly comfortable restorations. So I wanted to put up basically the new progression of how we take care of a tooth that's cracked or deep decay. The decay wasn't a lot of decay here, but I wanted to show the kind of restorations that we're seeing in dental schools. The dental students, you dental students, are doing tough composites. I mean, big composites, cuspal replacements, cracked teeth, restoring teeth with endodontic treatment that have to be stabilized. So before we move on, are there any questions about the logistics or cavity preps or the steps in a cuspal overlay case using the modern Clark preps and modern injection molding? And this case was treated with Filtech 1. Filtech 1, I want you to look at the aesthetics of that. Most of these bulk fills are ugly and grainy. Filtech 1, this is a 5 millimeter depth of cure. That's really pretty stuff. That's a B1. So let's stop.
Can you review the flowable curb concept?
We want me to review that?
Yeah, just exactly what you're doing and why.
Okay.
That was new to our students, that's why.
You want me to do a live demo on how to do that?
No, I just explained the concept and the purpose. I know exactly what you did.
Okay, great. Well, I'm glad the students are fully caffeinated and watching. All right. So what we do is, one of the hardest things to do with composite is to actually adapt it to a margin. Now, a lot of the schools are still teaching amalgam. We're still teaching amalgam at McGill, aren't we, Taras? John? Yes?
Yes, we are. Yes, we are.
Okay.
Yes, we are.
So one of the things that I used to love about amalgam, I loved to do it. I don't do amalgam anymore, but I loved it, right? And one of the things about amalgam is you pack it and burnish it and have this beautiful margin. And you really, with amalgam, you've got this definitive margin, and amalgam kind of loves a margin, and you pack it there and you cleanly burnish it away, and you can create a great margin. Composite is the opposite of that. When we manipulate the composite and try to marginate it by hand and manipulate it, you ruin it. So with the Learning Center, what we teach is intentional excess at the tooth restoration interface. We're going to go past the margin to an infinity edge, And one of the things that helps us to get those open margins that you see is we don't marginate the composite. We actually leave intentional excess at the margin so that it shrinks toward the margin. And then we bevel that and have an infinity edge where it goes actually past the margin. And the curb helps us to do that, because when I take that flowable curb, I use it cold around and put it just past the margin where the infinity edge is. That creates a catcher's mitt in baseball, or what is it in hockey? It's a trapper. What's it called when you get the puck? What's that thing called? What is
Trapper.
A trapper. Wasn't a great word, right? This is your trapper for hockey, okay? And so as I injection mold, that helps me to injection mold against resistance. And then I can pinch the composite off against the curb, but now I'm not opening up the margin, because this is helping to protect the margin during injection molding. So we want to get away from manipulation. So the curb is doing two things for me, John. It's creating like a second matrix, because I've got good containment where the matrix is right here, but I don't have good containment at my calla lilies and cuspal overlay areas, because we don't have a definitive margin anymore. I got to have something to help me with my injection molding to get good thixotropic flow. So it's my catcher's mitt. And this curb is incredibly effective. I mean, I know that Raphael and Joshua probably, and Taras, how often are you using this flowable curb, Josh?
I would say more often than not, because as we know, the background fluoridation of these teeth are often so high that, many dentists will go ahead and try to do a sealant, or, see a little bit of staining in the grooves, not decide to use caries detector to open it up, or using disclosing solution, and you open just a small occlusal groove and boom, you're going to get these, large occlusal caries. And with heated and injected composite, if you don't use this, you're going to wind up getting all over, the proximal surfaces. And this actually is much faster. It makes the finishing and polishing very quick. And the results are just beautiful afterwards. So this does not take long to do. I would say majority of the time I'm doing occlusals, I'll do this. And we're going to provide some video examples that we have of it as well.
Right. And so as we build our model, certain things are becoming more and more important. And this ability to have a containment system beside just the matrix allows us to do bigger and bigger cases. So I'll take a case where if the cusp is broken off, I'll do 2 or 3 of these layers as a second matrix to have something to contain. We need to inject into a pocket. I want to inject into a pocket. Injecting onto a flat surface, it just goes whoosh, like that. So John, it's kind of hard to explain without doing a demo, but we'll give you more information about the curb, but it is super.
That was an excellent explanation. We're good.
Good,
Thanks.
thank you. All right, and thanks for asking, students. We're here for you folks. All right, so there we are. Now we put the tooth into compression. Pat loves his tooth. And there was a prosthodontist and a friend of his that wanted to put a crown on there, and Pat says, no way, I want an overlay. And so Pat's, he walks around telling everybody he chews on nuts, and he's trying to break this tooth, right? And it's super comfortable. So these are compression-based restorations. Now, whenever we do a composite, the composite can absorb 1% of its volume in water. So you notice that the occlusion is a little bit lighter on this tooth than the other teeth, because the composite is going to absorb water. We don't want the tooth in hyperocclusion. We don't want your patient coming back into the clinic to adjust it when the bite is high. So we have the teeth are in slight hypo-occlusion, because like I said, the composite is going to absorb 1% of its volume in water and get bigger tomorrow. So we want light occlusion on the composite. All right, so we're going to play a little game. Now this goes way back when I was a kid. In fact, before when I was a kid, it was called the $10,000 pyramid, where they'd go on TV, right? Look at this whole thing. Anyway, we're going to talk about the $10,000 pulp cap game. And students, one of the things that happens in today's world is our patients are more and more sophisticated. They obviously have access to all the scientific information at their fingertips on their phone. And so patients have high expectations for dentistry that they maybe didn't have when I graduated, right? They're going to look at your dentistry very critically now. And so I'm going to just tell a little story about the $10,000 pulp cap, okay? So the theme of the lecture is the $10,000 pulp cap. And let me explain how this works in private practice. When you have a patient come in to your practice, whether you're an associate or you're in your own practice, basically they are testing you. And are you going to fail the test or pass the test? So before we talk about the $10,000 pulp cap, we need to talk about selective caries retention. And so selective caries retention is something that is being either introduced at the schools that we're working with, or is now part of the curriculum. But on almost every dental school, students, you'll have faculty who are teaching selective caries retention as something that we always do, versus something where people say, no, you have to remove all the decay because G.V. Black in 1890 mandated that all the caries had to be removed. So this is an area of, unfortunately, some controversy. So we wanted to give you some good science that we've been putting together at the Learning Center. So these are all the studies these are just a small sampling of the studies that show selective caries retention. And you look at these success rates: 100%, 97%, 89, 96, 92, 100, 100%. And the thing that's interesting about selective caries retention, or leaving decay, I don't like to say leaving decay, it sounds like you're lazy. Selective caries retention sounds purposeful. The patient comfort matters. Patients go home with selective caries retention and they have no pain. They have no sensitivity ever. That's important. And so here's some more studies: 80%, 95%, 97%, 95, 96. Unbelievable success retention of the pulp when we leave decay in the deepest areas. And then I want you to take a look at direct pulp capping. And so we still have some faculty members that say, no, remove the decay and do a direct pulp cap. The survival of direct pulp capping, look at this: 67%, 50%. That's a 50% failure rate. So let me ask you something. You have a patient coming into your practice when you get out of school, and they have deep decay, and you say, well, we're going to remove all the decay because that's what I was taught. There's a 50% chance that you're going to have a lot of pain and need a root canal and maybe have infection. 50% chance? Who would choose that? You are not going to find direct pulp capping studies, direct pulp capping that have high success rates. I tried it in my practice. I had lots of patients with pain. I am so disappointed that I listened to some lecturers who said, oh, direct pulp caps are great. Put some MTA over the pulp horns. It's awesome. I had lots of patients that needed endodontic therapy, had pain later. I'm embarrassed that I listened to bad science. And so direct pulp capping is something that really, it is not a patient-centered outcome. Patients really don't want to have this kind of problem. So once again, the $10,000 pulp cap. Okay, so here we go. Here's Kathy, the first of the $10,000 pulp caps. Okay, why would a pulp cap be $10,000? Let me explain. Kathy has been undergoing orthodontics. Kathy is waiting to do a $10,000 rehabilitation of all her upper teeth. She's going to do a big aesthetic reconstruction of her teeth. She's been putting it off, and now all of a sudden she's got decay. And this decay is pretty darn deep. And so if she says to me, she goes, you know what? You're telling me that I've got deep decay. I can't even feel it. She goes, if this tooth can be comfortable, if you can remove the decay in my teeth and I have no pain postoperatively, I'll go ahead and schedule my $10,000 treatment. Now, I know that may sound ridiculous. When you get in private practice, you'll get these kind of challenges. So the question is, can I put this tooth into compression with an overlay and not have postoperative pain? And I said, we almost never have postoperative pain. When your patient comes in pain-free, they expect to be pain-free the next day. If they come in pain-free, they have an expectation of being pain-free the next day. Whether that's reasonable or not, I think I can provide that, and today I pretty much do. So here we are with Kathy. There it is. One of the problems with these new digital x-rays, is sometimes the caries, when it gets deep, it kind of disappears. On old-fashioned x-rays, I can see deep decay. This thing is mush. This tooth is mush inside. And so they tend to kind of sneak up on us now. So this is the decay that I'm assuming that she has in the tooth. And so when I go into a tooth like this, I have a plan. My default treatment is I know that I will not expose the pulp. No matter what, I will not expose the pulp. So I'm assuming that her caries goes right here and there's a mesial buccal pulp horn right there. So my plan is to leave the internal caries and provide a great external seal. I'm planning on leaving that decay right there. That is job one in modern dentistry. You'll have no postoperative pain. You have a 95% survival rate of the pulp, and the patient will love you, and you'll grow your practice. You're going to do the right thing for the patient and the right thing for your practice by doing selective caries retention every time. So there's the case. And here she is postoperatively. You can't even see on a radiograph most of the time the selective caries retention. She's got selective caries retention right here under the restoration. So we're very aggressive to remove decay peripherally. She is 55 years old. So in her case, I can be more aggressive about removing caries at the periphery. So this is age-based. Now, Dr. Solomon, in your pediatric practice, you don't have that luxury. And a child, those pulp horns are massive. So if you're Dr. Solomon doing a kid, your amount of peripheral caries removal is going to be less. You're going to have to get an even more careful external seal because they've got this huge pulp chamber. So in a 55-year-old, I could be a lot more aggressive about removing caries peripherally, but there is selective caries retention right there. She had zero postoperative pain. She said the tooth felt amazing. She had zero postoperative pain, and she actually scheduled, after this whole thing is over, she scheduled out and whatever to get her big rehabilitation case done. All right. So I won the $10,000 pulp cap game on Kathy because I did selective caries retention. She had zero pain afterwards. Teeth and compression. I did a cuspal overlay on the mesial palatal and mesial buccal cusps. She was great. All right. So the purposeful caries retention is right there. That's where it is. And when it's done carefully, everybody worries that it's going to look like recurrent decay. It doesn't look like recurrent decay. So let me ask you something. If a patient, if anybody looked at this x-ray and said that that little tiny dark spot right there was secondary caries, they don't understand x-rays. So we actually have a new algorithm, new thought process. We have to start looking at caries now, understanding that selective caries retention is now the norm. And we have to start getting used to seeing dark areas underneath the restoration in the center of the tooth and not thinking that it's a void or not thinking that it's a recurrent decay, because recurrent decay starts from the outside in. So I wanted to bring up our panel of experts. And I know we were talking to Dr. Robles from Alabama. We need to start talking about, how we're having these conversations about radiographic presentation of selective caries retention and the whole legality and the politics of that. But carefully done, most of these time actually you don't see the it doesn't look like recurrent decay on the x-ray. So Dr. Robles, any thoughts here?
No, but I love the fact that you're bringing this up because this mindset of having to excavate everything, whether the pulp survives or not, has been so toxic and so destructive in our profession. I'm loving this sequence, by the way.
Toxic and destructive. Did everyone hear that? How do you really feel, Dr. Robles?
Oh, let me tell you.
Toxic and destructive. Write that down, Dr. Solomon. Write that down, Dr. It is toxic and destructive. And so I think, students, times have changed. When I went to dental school 100 years ago, there were very few controversies. Welcome to the new world. It's exciting. You're going to have to choose sides, essentially. You got to choose what you're going to do for you and your patients. But there's a massive movement, and there's a lot, and the science is behind it. The United States and Canada are actually behind the rest of the world. United States and Canada are behind the rest of the world. Almost everywhere else in the rest of the world, selective caries retention is just the norm. It's not even a controversy. So there you go. From Dr. Gross or any of the faculty, the whole thing about now we have to rethink the way we look at our radiographs. Isn't that interesting? Dr. Konenek, comments?
What about a similar approach with pediatric, with primary teeth? Is it, Dr. Solomon, is it a similar approach?
Right. Yeah, that's one of the things that we put in the articles for the position papers. There's a big shift, even the last few years, of selective caries retention, especially in primary teeth. We're actually seeing a lot of that now, with the pandemic, because as an emergency basis, we're not using handpieces. And so, the Hall technique or the Hall Smart technique is being used more and more. So this has really just become the standard. And you know, the issue previously and why this technique was not used as much in pediatrics is because we didn't get a good seal on our restorations, right?
Right.
And if you were just going to put an amalgam or you know, a composite, posterior composite, that most of the time the way that they're doing bonding is they're you know, these restorations are leaking. If you don't get a seal, I don't care what you're doing inside the tooth. I mean, we have to have a peripheral seal. So,
Right.
and that's why we get away with it with a stainless steel crown. But if we're doing these restorations where we're wrapping our composite around, you know, mid-buccal, mid-lingual, and we're grabbing 70% of the enamel, and we know for a fact we're going to get a marginal seal every single time. There's no question that why would I start treating the pulp in many of these teeth?
Right.
You know, every time you go into that pulpal tissue, I see, although it's successful, we see a much higher rate of external root resorption, internal root resorption, primary teeth coming out. And now you went from, you know, removing all the caries, doing a pulpotomy, to tooth exfoliating early and needing to put a Nance or a banded loop, right? So it's not just the tooth itself, it's what's the orthodontic maintenance after that tooth comes out and exfoliates early.
Right. Thank you.
So this is also interesting. They were talking about selective caries retention 100 years ago when I was in dental school. But here was the thing. When I was in dental school, the only people talking about selective caries retention were frankly kind of the sloppy dentists over at the like the low income place where they couldn't afford to do root canals. And these dentists didn't use rubber dams. They didn't have good restorative seals. They didn't use gold. So we had a bias that the people doing selective caries retention, this was just for low income people or dentists that weren't fancy, great dentists. You're looking at some fancy folks here. Dr. Joshua Solomon, you know, he's a high-end pediatric dentist. And, you know, this is state-of-the-art stuff. This is not just because we're desperate. This is now the best dentistry you can do. And so we have to get over this bias that old guys like me think, oh no, they're sloppy. Oh, they're just lazy. Oh, they're only treating like all these people who can't afford good dentistry. No, this is the $10,000 selective caries retention. So this is the other thing is we have a bias that's now the opposite. The best dentists in the world are now doing selective caries retention.
And I'll ask parent frankly, and we'll have a discussion about it, you know, for your child or, you know, your 8-year-old, your 9-year-old, your 10-year-old, we can remove all the caries and have a pretty high rate of needing a root canal, needing endo. What do you want to do? And I've yet to have someone in years tell me, no, go ahead, let's temporize it and send you to endo with, you know, incomplete apices. I've yet to have a parent do that, right? Because the end result is the end result. It's going to need endo, right? But you think about how much, you know, how much tooth structure you're removing in endo access, and then you're relegating that tooth. You're starting that process of tooth death at 8, 9, 10, 11, 12, where they're going to hog out that tooth and endo, and then you're going to have to place, you know, a stainless steel crown by the time the endodontist is done with it, hogging out all that tooth. And we know the tooth heights are on, you know, we don't have a lot of passive eruption yet. And especially, you know, a second molar on a 12, you may have this tiny, tiny bit of tooth height there, and trying to get a restoration on that and drill that whole tooth down, that is exponentially more destructive than selective caries retention. But the key is, we said it before, is getting, you know, a good rubber dam and magnification. That's why so many of us have gone to much higher power loops than a microscope. You know, we're talking about, you know, about really being able to fully see periphery around the dentin. And if you're using 2 powered loops, it's not going to happen. Not going to happen.
So the last thing that we're going to talk about before we move on, I really appreciate everyone's comment, was Dr. Solomon's talking about informed consent. So he's getting informed consent from his patients saying, we're going to do selective caries retention. How do you feel about that? This is interesting. If I was to give a number to selective caries retention in a practice that does careful dentistry with good case selection and a good tooth restoration interface, doing the Bioclear method, your success rate should be 95% or better. So only 5% of those teeth are going to need endodontic therapy later. So we're giving informed consent that basically there's a 5% chance that you may need a root canal later. What's the pulpal death rate for a full crown? What is the pulpal death rate for a full crown? Anybody know on average? What percentage teeth with crowns need root canals later?
70?
No, it's about 15% on average, okay? And a lot of times we don't give informed consent when we do a crown. We say, well, after I do your crown, you know, that's kind of hard on the pulp. There's a 15% chance you'll need a root canal. So we're not really asking for informed consent or giving informed consent generally in dentistry for crowns, even though they have a 15% rate of pulpal death. So yes, you can do informed consent. I'm to a point now where I'm sort of so used to selective caries retention, I'm starting to not worry about doing informed consent because it's just sort of implied. So informed consent is something that's great. Patients should be informed of everything, but I think it's funny that we're kind of talking about that. So back to the point, with proper design and technique, the retained caries will be radiographically indiscernible in many areas. And even if you can see that little tiny bit of darkness right there, because I'm looking for it, nobody should think that's recurrent decay, because recurrent decay starts from the outside in. If you've got recurrent decay, you're going to see it around the margins first, okay? And that's the opposite of what we're doing with the restorative procedure. So here's Tatiana, all right, the next $10,000 case. So why is this a $10,000 pulp cap, okay? Well, Tatiana came to my practice and she had been to 2 other dentists before me, okay? This is common, all right? Students, welcome to the new world. This young lady is testing me. Now, Tatiana has got 10 family members she wants to refer into my practice, sisters, brothers, wife, husband. And if everything goes well with her, she's going to send all of her family in. And so the average patient will bring in, let's say, $1,000 a year in average treatment. So she's going to refer $10,000 worth of treatment into my office. I mean, I don't think in those terms. I don't, to me, it's always about being a good doctor. But at the end of the day, you have to pay your bills. So when you make a mistake, and you have an unhappy patient, that's going to cost you $10,000. When a patient and their family and their friends leave your practice because they don't like the outcome, because maybe you picked a procedure that's outdated, that's a $10,000 loss, okay? So the doctor lost $10,000 because Tatiana came to see me, okay? So here's the post-operative radiograph that was sent from her previous dentist. I want you to look at the way that they burrowed in laterally to remove all the decay, because that's what good dentists do. So they burrowed into her tooth. They took out an old composite that was fine. She had no pain. And the doctor said that there's decay, your doctor left decay. So the new doctor went in, doctor number 2 went in and burrowed in there. What is the clearance between that composite and the pulp? Nothing. That's a guarantee for screaming pain. So she had pain, 9 out of 10 pain for 3 months to cold and just to cold, not chewing, not hot. So the tooth has reversible pulpitis, but it's severe and it's getting worse. And she's had it for 3 months. This tooth hurts her every day since it was filled, every day. It's almost inhumane. It's almost cruel to go into a tooth and do this and then have a patient have pain for 3 straight months. I thought that was just what we do. We make teeth hurt. That's what I used to think. So that's what the doctor did to her. And she said, you know what, something's wrong here. And so she came to see me. So I interviewed her and I said, well, this is my periapical that I took. I said, well, here's what we're not going to do. We're not going to take the composite out and hope that something better will come. We're not going to put a crown on it. I said, there's nothing I can do. You can wait and see if this thing calms down, which could happen, or you can do endodontic therapy. And she said, well, it's COVID and I'm going to wait. And so I said, it's up to you, right? But realistically, at this point, we have to do endodontic therapy, which it's sad, but that's the only thing that's going to help her now. She has pain every day, 9 out of 10 pain that lingers for 20 seconds with cold. So she finally comes in. I do the endodontic therapy because she just can't wait anymore. And you know what was interesting with Tatiana? After I did the endodontic therapy, and you can see with the endo that I went right through the composite into the mesial buccal. That is just strangling the tooth. Look at where the access for the endo was and look at where that composite was. It's just the wrong treatment. I finished the endodontic treatment, and with modern endo, we don't want to, we don't want to overfill. This is a conversation for a different day. So we stay inside the canals on these vital cases. We don't get a lot of extrusion. She had 0 postoperative pain. And when I took the rubber dam off, this was key. When I took the rubber dam off of Tatiana, she took her tongue and she rubbed it on the tooth. Because in my practice, doing cuspal overlays and polishing and making an amazing occlusal softness and smoothness. She put her tongue on that tooth and said, that tooth feels amazing. Why do all my other teeth feel so jagged and rough? I said, that's the Bioclear method. And Tatiana says, okay, you win. My family of 10, we're all coming here. And like I said, all the pain went away. She could feel the difference of a tooth in compression. I showed you the other tooth where we create these beautiful, almost like crowns with the Bioclear method, and she feels great. And so it's key, especially now, because she's not going to come back for a while. And, you know, this is a nice, like I said, I removed most of the old composite and I put it into compression. That's what it looks like radiographically. So that's the $10,000 pulp cap. Now, if I had been dentist number 2, this is what I would have done when I did the composite the first time. And that's the selective caries retention that should have happened, but did not. If I would have been doctor number 2, replacing the old composite, I would have gone into the tooth and said, if there's caries right there, it's staying there. My plan is to always leave that lateral caries every single time. That's really the model that we have to look at. So if this dentist would have just left that little bit of selective caries retention internally and provided a good external seal, Tatiana wouldn't be in my chair. Tatiana wouldn't need endodontic therapy. 95% chance she would have been okay. And he wouldn't have had a patient who disliked him and was writing bad reviews about him online, that he wasn't modern. So it gets worse, okay? So then I said, Tatiana, when I was talking about endodontic therapy, she drags this up. This is on her cell phone. She says, the doctor did a cone beam of my tooth. I said, the doctor did a cone beam? Oh yeah, he's got a $100,000 machine. I said, yeah, they're expensive. And she said, he took a cone beam of my tooth because he couldn't understand why it was painful. This is how bad it is, folks. He couldn't understand why my tooth was painful because he did the right treatment. So he says, maybe your tooth is cracked. He was just in the tooth. He should know if the tooth was cracked. This poor doctor, he's not, they sold him a cone beam machine. They sold him on full caries removal. His patient's traumatized, and now he's confused. He doesn't know why the pulp is screaming and uncomfortable. So he took a cone beam. I said, how much did that cone beam cost you? She said it was expensive. It was $240. That's not how we detect coronal fracture. We use a microscope to detect coronal fracture. You can't see a microscopic crack in a cone beam. So this kind of brings up how confused our profession is, because we don't understand why teeth are uncomfortable as far as the way the pulp reacts to this pulpal intrusion. All right, so let me back up here a little bit. And so do we have any questions from the students about Tatiana's unfortunate experience with this, supposedly modern dentist, and why she left this guy's practice, and why, running into the pulp like this and getting really close to the pulp, flirting with the pulp is something we just don't do. And something that with the curriculum that we're developing, this is the inverse of what we should be thinking about. Pulpal protective caries excavation. Pulpal protective caries excavation is part of the plan. You go in with your number 1 objective, don't hit the pulp. That's a new. And we got to leave some decay to do that. You can't get super close anymore. That conversation's old. That's what this guy tried to do. He tried to get as close to the pulp as he could and not hit the pulp. It's not sustainable. All right, so any questions?
There's 2 student questions. Do you injection mold all the way into the pulp chamber, and then after Bioclear, would Tatiana still need a crown?
Oh, awesome. Okay. We have a whole section on how to do overlays on endodontically treated teeth. That was in a webinar that I did last Wednesday. That is recorded. I want the student to go to the recording from Wednesday. I actually did a case where I did endodontic therapy. How do we stage the endo and the restorative? How do you fill it? And we've got, that was at the Wednesday webinar. So let's have the students tune into that. And if we want to do a webinar in the future about more overlay cases and treating endodontically treated cases with injection overmolding, holding, let's do it. Whatever student that was a perfect question, because now you're thinking ahead. Hey, David, how do you restore this? So yes, we injection overmold. This was 3 layers. I had to put bulk fill flowable down here. I did 1 more layer here. And then once I had about a 4 millimeter shell of injecting, then I injection molded the rest. So in an endo teeth, you're going to need 2 or 3 layers. So you're going to have to put bulk fill flowable down over the stumps before you do anything. And sometimes I can just do it with double shot, but you have to get that bulk fill flowable into the stumps, covering the floor, cure that, and then injection overmold, because you're way deeper than 4 millimeters here on the occlusal. Good question. Other questions, Josh? Are we good? Anybody have a question about this tooth before we move on?
I have a
Go ahead. No, go ahead.
Oh, I have a comment only. This is wonderful case because this is showing how technology, without the proper concept, will lead you to, you're on the verge of taking this tooth out to put an implant because you're thinking the wrong thing with the right tools. And that's very scary. Love this case. Love this particular case.
Thank you. Yeah, these are the cases where you go, oh, we've got a problem, right? We have a problem in our profession, right? So anyway, now let's look at a brighter picture now. Here's David, came into my practice. This is when I just started practicing caries retention. So he's got decay basically into the pulp chambers of every tooth. All are asymptomatic. We're going to talk about why these teeth are asymptomatic, even though the caries is almost into the pulp chamber. So I said, David, we're not going to do root canals and crowns, even though that's what I would have done a few years ago. We're going to do selective caries retention. In the anterior, it's a completely different animal. The anterior is different. So what we're going to do is, here's this sort of circumferential decay along the gum line. But all I need for the Bioclear method is clean enamel or dentin at the subgingival area. These are the apple core preps. There's caries indicator. And the one thing that caries indicator is going to show you here is that I've done selective caries retention. So see that zone right there? That is not pulp. That is the purposeful caries retention. Leave it, leave it, leave it. Shrink wrap the tooth, blast it, sand the contacts, injection overmold the teeth. We talked about this last week. We injection overmolded some anterior teeth. I hope that you and Taras asked for that. Tell us, just do live demos last week. We did a bunch of these teeth. How do you injection overmold a tooth? Quickly, efficiently. Now, you may think that the anatomy of these teeth are weird. You know what? In a patient like this, the last thing you want are black triangles full of food. So that is unsustainable. This is the Bioclear method, and it works. Now, I'm going to show you his case. We treated him in 2010. We tracked him down. Here's his 9-year post-op. Guess what? No endos. Now, this is old. You see a little brown spot here and a brown spot here. I wasn't as good as I am today. The Rockstar polish is mediocre, right? Hey, I'm better today, but I'm so proud of this case because all the pulps are there. You got a patient like this, the last thing you want are a bunch of margins. Let's just shrink wrap the teeth with the Bioclear method, selective caries retention, off we go, right? So, like I said, I can do much better today, but I'm proud of that. I am proud of that. So, some quick topics for conversation in our time together. We've got about another hour. Why and where is the pulp fragile? The power of pain, the promise of comfort. Let me tell you something. In a modern practice, you can almost eliminate all your postoperative pain. I didn't believe that in the old days. So we thought, oh, when you work on teeth, they're going to hurt. Not anymore. Long-term outcomes, upstream versus downstream pulpal insult, and then monetizing the method. At the end of the day, you're in a fee-for-service practice. You know, you need to be compensated for being a good dentist. You need to be compensated for being more conservative. Unfortunately, dentistry, the more we cut, the more we extract, the more we drill, the more we get paid. Unfortunately, that's the model. So we want to help you to get paid for being conservative. One of my old professors says there should be an enamel preservation fee, right? So we actually have a separate fee for selective caries retention in our practice on top of the composite fee. And the insurance company doesn't pay for it. And we tell the patient, well, you know, we can do a root canal. If insurance will pay for that. And a lot of dentists would just do a root canal, like that guy, root canals, posts, and crowns. So, you know, there's an additional, and I'm not going to give you a dollar fee, but there's a dollar fee that will be just charged for a selective caries retention. It's on top of the composite. So it's, you know, you can charge for this, and if you want, right? So we've got old legacy concepts. So we have pulp capping as a lexicon. We don't call it pulp capping anymore. The official position at the Bioclear Learning Center is SCR, selective caries retention. That's a consensus statement between all the schools. So from this point forward, we're going to call it SCR, selective carriage retention. Pulpal encounters, chemotherapeutic versus microsurgically driven. All the conversations up till, well, a lot of the conversations up until now were about what kind of sauce, what kind of stuff do I put over the pulp? What we understand now is when you look at the studies, it doesn't matter. It actually doesn't matter. If you get a good peripheral seal, in Brazil, they did a study where they put wax. They did wax over the selective carriage retention and then put composite on that. It had the same outcome. So what kind of chemistry you put over the frank caries doesn't matter, because you can't bond to frank caries anyway. So we're going to let the tooth heal itself naturally and heal all that little bit of selective carriage retention that we left deep in the tooth. It heals. It's sterile and hard within 6 months. And when Rafael Bustamante, we did the lit search on this, there's an article in there talking about, you can see the calcification process over time, where the body heals it because the pulp just pumps stuff into dent tubules. We'll show you. So it's a microsurgically driven model, not what kind of sauce do I put in there.
Dr. Clark, there was a question from one of the students a little bit ago, and basically they were asking about if you have soft caries over the pulp, what happens with your restoration strength over the top of that versus, hard dentin?
Okay, did everyone hear that? Dr. Clark, panelists, they said, David, what about that soft decay you're leaving in there? Now, we have to think as engineers. And so for old dentists like me, here's what we used to think. So in the old days, we would do amalgam. And then deep in the prep, we'd put Dical. We'd do a little bit of selective carriage retention. We put Dical under the restoration. And that was deep in the tooth. We knew that Dical was essentially pancake batter, which is mush. So what we had to do with old-fashioned Dical is you needed 2 to 3 millimeters of clearance over the Dical with your amalgam. And basically what we understood was that is a structural liability. So you need to have enough tooth structure around the outside and enough thickness of a helmet over the soft little brain that the helmet's going to stay intact, right? So it's a football helmet, okay? You got a brain in there, and you've got this scalp here, and then you have to have enough clearance over that brain to protect it, because there's no structural benefit from the soft tissue. There's no structural benefit from the selective caries. So you've got to remove enough of the soft material for structural integrity. So that's a great question. We're removing enough decay around the outside to get a good restorative seal. Then you have to take enough soft tooth structure away on top of where the caries is, so that your helmet has enough thickness. If your helmet's thin, you're dead. So you're going to fail structurally in addition to micro leakage. So that's a great question that nobody was asking. Way to go, students. You have to create enough removal of the soft tissue for clearance. So you're thinking the right way. So I think that answered that okay. We're going to show that in some slides. Awesome question. Thank you, Josh. Okay. Margin-driven versus additive dentistry with the infinity edge of the Bioclear method. So if you have a margin that's sharp, you're not going to get a very good seal, and you're very limited as far as how much volume. When you do additive dentistry, like I did on that guy with all those anterior teeth with decay, I'm adding composite past the margin onto clean blasted tooth structure. I'm going to have 3 or 4 millimeters of infinity edge seal. I'll win the game. The seal is the deal. So if we get away from this concept of butt joints and margins, we're going to do better. For example, if you're using amalgam and doing selective carriage retention, it's going to be a little bit more difficult to get a good restorative seal as far as volume. Now, the thing about amalgam is it's pretty foolproof. So amalgam is easier to do, frankly, but we need 1 to 2 millimeters of seal. So chemically stimulated or insult driven versus natural dentin deposition. So in all the old studies, it talks about reparative dentin and how we put different stuff out here to stimulate the soft tissue, the brain, to put chemicals into the dentin. We don't want to do that anymore. I know that you can do it. The question is, should we do it? And we don't. I don't want to stimulate the pulp to lay down secondary and tertiary dentin. Think about this. When somebody hits their front tooth as a kid, and that tooth turns yellow over time, what's happening? It's called calcific degeneration. The problem with the pulp, everybody wake up, the problem with the pulp is once you make it mad, right? I mean, Raphael, did you ever get in a fight with your wife that lasted for 10 years?
I wouldn't be married still.
Okay. Here's what happens. It's like starting an argument with your spouse that goes on for 20 years. Once you infuriate the pulp, it stays mad. So I'm going to show you a case on that. So let's not make the pulp mad. Let's leave it alone. Okay. So yes, we can stimulate secondary and tertiary dentin, but eventually the pulp chokes itself off. So with calcific degeneration, you smack a tooth. 20 years later, the pulp gets smaller, 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 smaller. Eventually it chokes itself off. The tooth turned brown and then it abscesses. Literally 10 years later. It's been mad. It's been having an argument with itself for 10 years. Think about that, right? So what is the ultimate pulp capping agent? Well, is it Dical, resin modified glass ionomer, MTA, dentin in a capsule? By the way, all this stuff is expensive and hard to work with and has no restorative seal. All this stuff, other than good glass ionomer, none of these things have a good restorative seal. None of them provide any strength. What's the ultimate pulp capping agent? None of the above. It is a well-sealed tooth restoration interface and a little beret of carious dentin over the pulp. And we are leaving frank caries. We're not leaving piles of it, but we are leaving frank caries. So the conversation about affected and infected dentin, that's an old conversation. It's over. We have a clean area of dentin that's unbelievably clean, and then frank caries. That's it, okay? What are the 3 rules of selective caries retention? First thing is we have to have good case selection. The tooth has to be asymptomatic. Now, the patient may be getting food impaction to cause pain. You have to rule that out. But if the patient's having pulpal pain, you could try selective caries retention, but there's almost no research. Almost every study that's been done, the patients have no pain. And so with caries, it's yes or no generally. With cracked teeth, it's different. But with caries, they either are pain-free or they have pain. If they have pain, I would do the endo, frankly. So don't expose the pulp. Rule number 2 is don't expose the pulp. You can guess number 3, don't expose the pulp. These are the new rules for selective caries retention. And it seems oversimplified. It's a new day, folks. It's a new day. So selective caries retention, or they call it the modified Hall, but we're going to clean up the lexicon. And from this point forward, it is selective caries retention. There are 10 different names for this, and that's fine. It'd be nice if we all spoke the same language. So with our schools and with each other and with the Learning Center, it is from this point forward selective caries retention. We've got to have good case selection. We have to have a clean apical on the radiograph. It needs to be asymptomatic. We do have some food impaction. Sometimes that will confuse you. Informed consent. Still, folks are still doing that. Compression equals comfort. Compression equals comfort. And can you achieve a good restorative seal on the periphery? In other words, if I'm going in and every once in a while I go into a case, especially recurrent decay under a crown, those cases oftentimes don't go well. I'm removing decay, and I just can't find a clean margin. I'm either going to extract or do endodontic therapy just because I can't get a decent restorative seal. But 99% of the time, I can find a restorative seal if I do good case selection. So here's the rubric for cavity preps with selective caries retention. This is what Walitha at Tennessee, Dr. Walitha from Tennessee, she says, I need a rubric. So we're working on the rubric, okay? 1 to 2 millimeters of clean hard dentin with good color at the periphery. That's either at the DEJ or when it's just when there's no enamel left at the periphery of the tooth. So I need 1 to 2 millimeters of clean dentin, and that means a good color. Generally, at that point at the DEJ, it's got to be clean with good color. On a pediatric tooth, Joshua, you don't get 2 millimeters, do you?
You
Okay?
won't have much tooth left at 2 millimeters.
No. So this rubric is going to depend on the age of the patient, and for primary teeth, it's different. So the older the patient in a permanent tooth, I can get 2 millimeters. On a young patient, maybe 1.5 millimeters. On a pediatric tooth, 1 millimeter is all you got, right? Okay. 1 to 2 millimeters, good color at the DEJ, same thing. Why and where's the pulp fragile? This is kind of a cartoon that was from one of these one of these toothpaste that's desensitizing, but it's a great cartoon. So what everybody has to realize is the enamel that we have is like a helmet. It has no sensation. These are dentin tubules. We have 10,000 dentin tubules per square millimeter. 10,000 tubules per square millimeter. And every single dentin tubule has an odontoblast inside, and every one of those odontoblasts are shrouded in a nerve dendrite. You have 10,000 nerves per square millimeter in the tooth. Every time you cut the dentin, you infuriate the pulp. Every time you cut the dentin, you infuriate the pulp. And sometimes it takes the pulp 20 years to die after a crown. You can infuriate the pulp and it's mad for 20 years and it could die 20 years later. So it is fragile when it comes to these odontoblasts, so leave them alone. With the Bioclear method, we don't cut boxes. We don't cut mechanical retention. We have a lot less pain afterwards because we're not cutting into dentin just to create a box. So that alone is going to create a more sensitive, more pain-free environment, all right? So chemically stimulated versus insult driven, okay? So I'm going to show you a case that I treated back in the dark days, right? So here we are, and sunlight's coming through. Look at, I'm getting beautiful shadowing here, okay? This is a young patient. She is 6 years old, I believe, at the time. And this is what we see oftentimes. And Dr. Solomon's nodding his head, like, oh boy, here we go, right? Patient's asymptomatic. So I'm going in. I don't really have a plan. This was 10 years ago. What I would do today is I would go around the periphery, removing caries at the DEJ, and then doing either a calla lily or a cuspal overlay, depending on what tooth was left. Here, I'm just sort of drilling at the tooth aimlessly because I don't have a rubric. I don't know what I'm doing. I'm trying not to hit the pulp, right? I should be taking an outside-in approach where I'm going around the outside and leaving the frank decay in the middle, but I didn't understand that at the time. There's the caries indicator. You can see all the caries at the DEJ. This is when you stop. Just clean up the caries at the DEJ and either do a calla lily, a cuspal overlay, a fissurotomy, and get a good restorative seal, but I didn't know that back then. I should have ignored the frank caries in the middle of the tooth. I got deeper and deeper and deeper and deeper, and then all of a sudden you get that pit in your stomach because you do this, it's bleeding. Now here's what we're not going to do. We're not going to talk about what to do when we have an accident. That's an old conversation that someone else can talk about. Yeah, direct pulp caps, you might be 60 or 70% successful. That means a 30% failure rate. It's like talking about what do you do if you extract the wrong tooth. Running into the pulp chamber today is an accident. You shouldn't do it. On an asymptomatic tooth like this should never happen again in my practice. And I don't think this has happened in years and years. It just doesn't happen.
Dr. Clark, we have one student question regarding that. It says, despite our best efforts in student clinics, sometimes pulp exposures still occur. If so, is it worth continuing with Bioclear method or jumping to a root canal treatment?
Okay, so good question. So here's the deal. This is a great question. I'm telling you now that for the rest of your career, if you hit the pulp chamber, I want you to be sad. I want you to say, I made a mistake. And if the case is so bombed out, if the caries is so bad that during removal of the caries at the periphery, you hit the pulp. In other words, if you were doing it right, unlike what I did, if you're doing the right protocol, which is protect the pulp, protect the pulp, to protect the pulp, and you're going around the outside of the tooth and maintaining that little beret of frank caries over the pulp horn, and you hit the pulp because it was a bad case, then it was a bad case. Let's let it be a bad case and not you be a bad operator, okay? I was a bad operator for a long time. I was a bad operator here. So if you're doing the proper protocol and getting a clean border and the tooth was just a mess, it was deep, there was not enough clean tooth structure on the periphery and hit the pulp, I think I'd have a conversation with the patient and say, there's at least a 25% chance you'll need a root canal later. I can control the bleeding I'll use actually bleach, sodium hypochlorite, and then you would put MTA over the pulp or one of these weird, voodoo things that they have and cross your fingers. And some patients will say, yeah, roll the dice. I'll risk a bad toothache, but I would give the patient a choice. And it's going to happen, but it shouldn't happen very often, young person, okay? I don't want to have you running into the pulp very often, only in a case where you just couldn't get a good seal. That's an awesome question. Now, here's my case. We went ahead and injection over molded tooth. I put a little curb there. Look at my white line right there. This is before we had the Filtech 1 book fill and before we had modern preps. This should have been a flattened calla lily and not just butt joint, but it is what it is. It's an older case. So this is the little girl. Preoperatively, you don't see much decay there. That's the problem with these radiographs. There's so much enamel that you're trying to cut through. You're trying to as you're shooting these x-rays through the tooth, the enamel blocks the caries. So this is gross decay. You just don't see it on the x-ray. It's just how it works on an occlusal caries. Here's a 1-year post-op. I had composite literally sitting on the pulp horn. Here's the sad thing. This is on one of my best friends. This is one of my best friend's little girls. She had pain every day with this tooth. Every time she put ice cream on the tooth, she cried. Every time she came in for a cleaning and we polished the tooth, she cried. But the pulp stayed vital because it was such a young tooth with immature apices. So I got lucky, right? So here's her 2-year post-op. She still has pain and cries every time we spray water on the tooth. The pulp's unhappy. Here's her 5-year post-op. At 5 years, the tooth finally stopped hurting. So I'm thinking, yay, I was a pretty good dentist. And then I want to show you what this thing looks like at year 10. So what the problem at year 10 is that you see pulp stones developing. The tooth is still inflamed. It's going to be inflamed forever. This tooth is going to have chronic inflammation for the life of the tooth. And this thing could end up needing endodontic therapy 10 or 20 years later because I made a mistake. So I'm going to show the contralateral side. Here she is at whatever, 7 years old. And here's her 10-year post-op. I feel good. I kept the tooth vital. She didn't need a root canal. So even though that technique was outdated, I'm very proud that I was able to save the tooth, even though today it would be very different. We got away with it because she was young. Let me tell you, you do this in an adult where the pulp doesn't have such a robust circulation, it's not going to go your way very often. They're going to need endodontic therapy a lot sooner. So here she is, 2009. Here she is, 2019. Young people, document these cases. Document them for a lifetime. We don't see these long-term cases very often. Document them. We learn so much from them. So here's the tooth. I want you to look at the contralateral side. I want you to look at how big the pulp horn is on the mesial buccal and how compressed the entire pulp chamber is. So creating reparative dentin is now something I don't want to do. With modern selective caries retention, if I would have done the case the way I would do it today, that mesial buccal pulp horn would still be there. Her pulp chamber wouldn't be collapsing. It wouldn't be having chronic inflammation like it is today. So it is a different thought process as far as what we're able to do. So my point is, not only did I obliterate the pulp horn here and make that area mad, I made the whole tooth mad forever, right? So it's different thinking. All right, so I'm going to show a case from the syllabus of a very similar tooth that I treated very differently. I'm going to show you how different it looks today compared to what I did 10 years ago, all right? So this is a tooth that's from the syllabus, same thing. We know that if we do full caries removal on this case, there's a 100% chance you'll be in the pulp. There's a 100% chance on this tooth that with complete caries removal, you're gonna run into the pulp. So what I did with this is I actually blasted the soft tissue away to get the clamp seated. And here's the decay. It goes right into the pulp. It's going right into the distal part of the pulp chamber. This patient is, I think, 16 years old. There's the decay going right into the pulp chamber. So what we're going to do now differently than I did 10 years ago is we're going to go outside in. I'm going around and around and around. I did a flattened calla lily on the mesial cusps. I'm going to do a cuspal overlay on the mesial buccal and distal buccal cusps. You see the caries at the DEJ? The caries at the DEJ has to go away. The caries at the DEJ has to go away. That's cancer. So there we are. Now we're blasting. So blasting is part of the selective caries retention protocol. So what I've done is here, as I've gone in with my little Christmas tree burr from the kit, and I've gone in at the DEJ and I've removed all the caries at the DEJ. I've got 2 to 3 millimeters of cuspal clearance, and so I go up, down, and up like that. And now I'm going to overlay these cusps, and this area right here, that is frank caries. That is soft caries, but once you blast it, you get rid of all the loose debris. And back to that really smart student's question, David, what about the soft decay? I've got to remove enough of that so I have a helmet. 3 millimeters is good. If I blast away all that loose mush, then I still have frank caries here. This is soft, but it's been carefully blasted. You put a spoon excavator in there, you put a round burr in there, you're dead. So we're maintaining that, and then we blast the frank caries. That's what it looks like. This entire zone, even though it's not red, the reason it's not accepting caries indicator, super, super soft caries won't even accept caries indicator. past the dentin. There's my curb. It's going to allow me to injection mold with resistance. So John, there's the curb again. You see, it's a big deal. There's my helmet. I put the tooth into compression, cuspid overlays on the distal. I'm not going to get crazy with a bunch of sharp, spiky anatomy that could break off later. This tooth's got to sit here for the next 20 years. I don't want anybody to touch this tooth for 20 years. And it should go the distance. And that is the amount of selective caries retention that I had to do on this extreme case. This case is actually harder than the case I messed up 10 years ago where I exposed the pulp. So let's stop and talk about what this looks like. And it is a compromise in our eyes for occlusal anatomy. Let me tell you something. This tooth has an immature apex. This patient is 16 years old. We got 1,000,000 miles to go here. And the first intervention is the key. Like Dr. Solomon says, pediatric dentist, the first intervention is the key. So let's ask everybody what they think about this case. This is in the syllabus. This is one of the purposeful selective caries retention cases. This is very ideal for a 12-year-old. Now, on that 55-year-old woman that I treated in the beginning, I didn't have to leave. I didn't have to have as much caries retention because the pulp was mature. So I could be a lot more aggressive about the caries removal, understanding where the pulp is. But let me tell you where the pulp is in a tooth like this. It's everywhere. So questions, thoughts? We're going to talk about the histology in a minute of why this actually works, why the body over time, as we track this tooth, you will see that selective caries retention will become hard and sterile. It's the opposite of what the old model was. In the old world, we were trying to stimulate dentin internally. I don't want to stimulate dentin deposition internally. Those days are over. What I want to do is sterilize the stuff up here. And the body will actually sterilize that pain-free, inflammation-free, naturally. That is natural dentin healing, because I'm going to show you in a minute the histology of why a healthy pulp can mineralize that over the next 10 years and have zero pulpal pain. This patient has zero pulpal pain, zero. Mom is ecstatic. Patient is excited. Okay, let's talk about this too.
Can you talk about, for your contacts, where you're adjusting occlusion here, what's your primary goals?
This is a tough tooth, right? I mean, everybody can go, what? Look how tough this thing is. I mean, look at this thing preoperatively, okay? That's a battle, folks. I want one centric stop in the middle of the tooth, that's it, okay? A lot of endodontists will tell you that that's exactly what you would want to see. And just so you know, there is no link between occlusal anatomy and mastication efficiency. In other words, if you do a lit search on occlusal anatomy, it doesn't determine mastication efficiency. Mastication efficiency is a neuromuscular event. Am I coordinated enough to chew? Do I have two hard surfaces that can bang together? That's how we tear food. So sure, it'd be more fun to put more anatomy on that tooth. I didn't have that luxury. You know, we have other battles to fight. So I would want one gentle centric stop in the middle here. That's about all you're going to get. You might get a little bit of function over on this mesiobuccal cusp over time, but that is, you know, we've got to buy time for this tooth to let it heal, to let the pulp grow, to let the tooth fully erupt. You know, 20, 30 years from now, I mean, I hope, you know, we could think about something that would have maybe more aesthetics and maybe contribute just a little bit better to coupling of the teeth. But I'm proud of this tooth, and I wouldn't do it any differently today. I mean, I barely survived as it was. That was a tough tooth, you know? So,
David, sorry, I just wanted to mention, you know, the whole concept for the benefit of the students is the cycle of death of a tooth. And it's really important to take into account the age of the patient here, because if we're going to end up in an endodontic situation, this is the next step into the cycle of death of this tooth. And you're one step closer to that quicker failure, quicker fracture, quicker implant at a younger age.
Yeah, and here's the other problem. In the old days, I would want to put a gold crown on this tooth later. Mom and the kid, they're not going to let me do a gold crown here. It's going to end up with a zirconia crown. Let me tell you about zirconia. It's okay. It's not as good as gold. And putting a zirconia crown on a lower second molar like this, that is pushing the cycle of death a lot faster, right? A gold onlay, yay. A zirconia crown, ugh. And a porcelain onlay here is hard to do because the tooth is short. So yeah. Other questions about this tooth before we move on? I want to talk about the histology of why this actually works and why the outcomes are so incredibly successful.
Dr. Clark, one quick question. When you adjust occlusion on these teeth, if you find you have a really heavy contact point or, a pretty solid contact point, do you find that even in a couple days or day or two, once this tooth rehydrates, you find that changes at all?
One of the problems I have is sometimes people's joints are swollen and so the teeth are apart. So if you ever get socked in the jaw, you can't bite your back teeth together. I know Dr. Konanek gets in a lot of fights. I heard that, so you get punched a lot, your back teeth don't touch. So one of the problems is they'll come back later and the bite they'll have hyperocclusion just because the joint has settled down. Composite is soft and it tends to kind of, you'll get an initial little bit of facetting there. It'll kind of, you'll be able to chew your way in, but I try to leave these teeth in hypoocclusion. And if I have an opposing cusp that's very sharp, we'll polish the opposing cusp. You need to get the patient's permission and your attending doctor's permission, but sometimes you have a super eruption or a plunging cusp. That doesn't help the patient. So we will equilibrate the opposing tooth sometimes. Is that a good answer there, Josh? Okay. All right, so here we go. We're going to talk about the histology and then throw up some more cases. Journal of Endodontics is a great source actually on selective caries retention. It probably has some of the best studies. Interesting, an article on endodontic, the Journal of Endodontics has some of the best articles about not doing endo. We have a lot of endodontists who are doing selective caries retention. Dr. John Cotomy joined us at one of the other ones. So we have a lot of endodontists who actually do selective caries retention on patients referred to them for endo. So think about that. Some of the best endodontists in the world get a referral from the prosthodontist. There's deep decay, it's asymptomatic. The prosthodontist says, here, you deal with it. John does selective caries retention, sends a patient back and says, crown it or whatever. That's a new movement. Some of the best endodontists in the world are trying to not do endo. Think about that. So what we're looking at here is a cross-section of a tooth. Let's pretend it's that little boy's tooth, the lower molar. Here's the pulp. There's the dentin tubules. There's the predentin. There's those little odontoblasts. Every one of them have a little nerve dendrite wrapped around them, and there's the pulp. So the question is, in this complex, it's pretty simple. Dentin tubules, predentin, that's immature dentin. Remember, the odontoblast laid a little bit of dentin down every day. It's like the rings on a tree, right? Every day those odontoblasts are working away, protecting the pulp, protecting the pulp cells, and every day they're moving. Every day they're laying down dentin. Every day, 24 hours a day, right? So that space is huge, 120 microns. That's like the size of two of these little Bioclear matrices side by side. So I mean, it's a big space. So what we're seeing here are the odontoblasts, and these odontoblasts do an amazing array of activities. These odontoblasts are secreting all these immunoglobulins that are actually going into the predentin, into the dentin, and healing the caries that you specifically left there to protect it, right? Look at all the immunoglobulins that the odontoblasts make, not the pulp, the odontoblasts. The odontoblasts have their own pain medication. They have opioids. So the odontoblasts are making medicine so there's no pain. That's why these cases with caries on every tooth have no pain. They have their own opioids to take care of themselves. There are other things that the odontoblasts make, TLR4 and a host of other things. When you read this, almost every single time, the cells that make the good stuff that keep the pulp alive and calcify the caries comes from the odontoblasts, not the pulp cells. It's the odontoblast, the odontoblast, the odontoblast. They are the rock stars, they're the soldiers. So what's the message? Don't kill the soldiers. Leave the odontoblast intact. They will heal the tooth from the inside, okay? So all kinds of stuff that the odontoblasts make. So here's Josh, modified Hull or selective caries retention. Josh comes in, he has zero pain. Josh has no pain. And he says, the last guy says, I need a denture, I need all my teeth extracted. I said, nah, you're asymptomatic, your x-rays look good. We're gonna do the Bioclear method. We're gonna injection overmold these teeth, and there he is. Now, This did not win Most Beautiful Smile at the American Academy of Fancy Pants, stuff, but it's a life changer. He had 0 postoperative pain, 0 postoperative pain. All these teeth are still vital 7 years later. And yeah, it's not perfect, but here's the thing. This was my cavity prep to do injection overmolding. There's my selective caries retention. Everything else was just mush or old composite. You see that little spike of enamel? I can shrink wrap that. And here's the cool thing. This dark dentin right here that's actually frank caries, in 5 years, that's going to be rock hard and sterile. Think about that. So we're gonna sterilize it the natural way, okay? But if I do endodontic therapy and take that away and take away all this to do a crown, I got nothing. So on a patient like Josh, doing root canals and crowns makes no sense. But with injection overmolding, it's a different animal. You cannot bond to aprismatic enamel. You cannot bond to aprismatic enamel. So what we're going to do is we're going to skim away some of the aprismatic enamel, put a good rubber dam on, and push the soft tissue away to find good enamel up here. I can bond to normal enamel, but not aprismatic enamel. That's going to have an iffy bond. We just shrink wrap the tooth. There's the umbilical cord. We showed it last time. We can do this. You can do these quickly now if you understand the Bioclear method. And there we go. And there's the postoperative. Now, I did leave little bits of old composite that was well bonded. We did selective caries retention, which you really don't see on the x-ray. And he saved up his money. And here I'm going to go. I exfoliated some soft tissue. This rubber dam is not very good. His wife was a dental assistant, and he insisted that she assist. And her rubber dams were not very good. So I apologize for the rubber dam. Anyway, there he is. So once again, whether it's a low-income patient or a fancy patient, doesn't matter. Selective caries retention with a good restorative seal. And I'll tell you, it's easy on the front teeth. Selective caries retention on anterior teeth is probably easier because the teeth are tall. I can get more insulation over the tooth. I think you put on some weight. What do you guys think? So any questions about Josh, my friend Josh? He's in the Bioclear book of selective caries retention. And in his case, he had insurance. We billed insurance for the composites. He paid a selective caries retention fee for every tooth in there. So I was compensated for being more modern. And I think that's only fair because, doing root canals and crowns or denture, I mean, right? He was happy to pay the selective caries retention fee on top of the composite fee. So any questions about Josh's case, everybody? Usually takes a minute for a case like this to soak in because it's sort of wild stuff, right? This is the HD matrix. This is actually the 360 veneer matrix. And I think that it wouldn't be a bad idea for the school to have the 360 veneer matrix. Taras, what do you think? Should the school have the 360 veneer matrix on top of the regular anterior matrices?
Yeah, so we have right now the HD matrices, one anterior kit, and we should definitely look into getting the 360s.
Okay, so at the Educator Summit coming up, we'll talk about, sort of what every one of these schools probably should have and get a consensus on that. And then, like I said, well, we've got great support from 3M and Comet to help sort of implement this in the schools. It takes time. We know that budgets are limited, but we're here for you. But if you don't have the right stuff, if you try and do this with a piece of flat Mylar, it's not going to work. And the students are like, what's the big deal? Why is a flat Mylar so bad? And why is shaped HD Mylar so good? Trust me, just trying to do this with a piece of flat Mylar, you're going to get frustrated and it's going to, you might survive the day, but it's miserable.
Clark, we have a student question. What do you charge for that 2 class 4 full 1/3 rebuild?
Okay, students are thinking about fees already. Good, because you have to pay back your student loans, right? Okay, here we go. Patient comes into my practice. If they have first-time decay, it's just an insurance procedure and whatever the insurance allows, because we still have half of our patients, half my practice is very insurance dependent. But if a patient walks in and they have a broken tooth or a tooth with failing, with cracks, incomplete fractures, and the tooth needs to be re-restored, if a crown would have been a reasonable choice in a traditional practice to replace, like that tooth we showed with the incomplete fracture of the mesiobuccal cusp, a total Bioclear overmold case like that, where we're upgrading the dentistry and putting a tooth into compression that was cracked. That's different than first time decay for sure. So what would I propose to that patient? Here's how it works. I say, your tooth is cracked. It's got an old restoration. Most dentists, including me, would have put a crown on this in a normal setting. So a crown is, let's say a crown is $1,200 and their copay is $600 and they're going to have to pay a $100 deductible, right? So their out of pocket for a crown would be somewhere in the $600 to $700 range. So our fee for Bioclear overlays is right around half the price of a crown. And we don't bill it to the insurance because insurance companies don't cover it. So we just say, I can do a crown. I can zip your tooth down. It's going to need there's a 15% chance it'll need a root canal. And sometimes crowns are sensitive afterwards. With these overlays, we typically don't get a lot of sensitivity. It's more conservative. Your out of pocket's the same. And we let the patient choose. And most of the patients say, I'll do the more conservative thing. What would you want in your mouth? I say something conservative. And we're not going to bill your insurance because they don't cover Bioclear overlays yet. I said in 10 years from now, they probably will. So you can pay $700 for a crown or you can pay $700 for Bioclear, and they typically choose that, but it's a conversation that you have to start having with your front office and everybody else. So the fees for Bioclear are going to vary. Sometimes you just do it for the insurance fee if it's a traditional filling, but as you start to get to the point where maybe a crown would have been something that someone else would do, now you can let them choose between a crown and Bioclear. That's when you can start to get compensated. So the answer is about half the fee for a crown for these overlay cases, and the patients tend to choose that. Josh, you okay there?
Yeah, and you're talking one appointment, no lab fee, and they look and this is one shade of body composite, and that's it.
Yep.
I've been to pretty much every fancy layering anterior course with 5, opacers. And I will tell you that the problem is you put layer on layer on layer on composite and it looks beautiful till they start biting on it and it breaks with all that air incorporation in it. And what patients care about is, the overall shape, the smoothness of the tooth. And what so many of us worry about in dentistry, what does the incisal edge translucency look like? Who likes that? That's for dentists, right? That's for dentists.
All right. So just to one up me here, this is Dr. Les Miller who did injection overmolding case with selective caries retention. Ready for this? Boom, right? So you get good at this, it impacts your treatment planning. This impacts your treatment planning. Injection overmolding is a third modality. We have bonding, which is okay. We have crowns. We know that crowns work. We have injection overmolding. It's a third modality. And that's the way that we're thinking about it now. And so once you really adopt the whole method and have confidence, we think of it as Taras, tell us in your practice now, in your private practice, is your staff and you thinking of the Bioclear as like a third thing? In other words, there's bonding and fillings, there's crowns, indirect, and then there's Bioclear. Can you talk a little bit about your private practice?
Well, basically what we're doing is we are giving patients the options, especially in the posteriors. I used to do a lot more porcelain partial crowns onlays, and now we're giving them the option to do it, instead of doing it in 2 visits, doing it in 1 visit, and doing it in resin.
Okay. And so one of the things that, we kind of brand it that way, which is that, this is a Bioclear procedure, because if we call it bonding, they're going to expect it to be $100, right? So that you want to begin to differentiate that. Okay. So the next thing I think is kind of interesting when we start talking about the pulp is this upstream versus downstream insult. This is some of the things I want you to be thinking about logistically, about comfort. Okay. So this is a great tooth, and I want you to really remember this tooth. This tooth has a facial composite that was placed. I can't remember why I extracted this tooth. It was just in the pile of extracted teeth. There was a facial composite, and look how the facial composite is causing that 10-year argument with the pulp. this is what's called an upstream result. So if you're in the woods and there's a dead cow sitting in the stream, you don't want to drink the water downstream from the dead cow, right? Everything that's upstream will contaminate what is downstream. So when you have a cervical insult, this is a problem with crowns, when you put a cervical insult here, you've got this huge blob of brain tissue that's unsupported. So you take a look at this at the pulp chamber here, it's wider here than here. And here's what's going to happen over time. It's going to get tighter and tighter and tighter until one day it has a heart attack and all this pulp tissue in the crown is cut off from cervical insult. So you also have to think about upstream versus midstream versus downstream insult. So when you have insults at the neck of the tooth, those are the ones where you run into the pulp. Those are the ones where you can potentially cause problems. So remember about the position of this because you're getting closer and closer to the pulp. The upside is when you have a downstream, which is here, when you have a downstream insult, you have a lot more distance between you and the pulp chamber. So here's the big thing, especially for pediatric dentists, there is no excuse to hit the pulp with occlusal caries. There is no excuse to hit the pulp with occlusal caries. That should never happen again, okay? You're down here with the upstream, that's a little bit more of a problem, and you may have more tendency for chronic sensitivity, but like I said, look at how the pulp chamber is not happy, how it's confused, and it's literally choking itself off. Now, we've never discussed this topic. This is a new topic that I haven't talked about for a while, but we're incorporating this into selective caries retention because now we're studying the way the pulp responds over 20 years. And a lot of these pulp cap studies are 3 years old. No. Let's look 20 years later and see what's going on. So I want to see what everybody thinks about this concept of upstream versus downstream versus midstream insult. Let's see if the students can kind of get their heads around what's going on here and maybe ask a couple of questions. Because remember what the odontoblasts are doing, they're working away, but when you infuriate the odontoblasts rather than leave them alone, they get confused. So these odontoblasts right here are confused because this insult's been chronically bothering them here. Can everyone see what's going on? This restorative intervention is now stimulating artificial dentin deposition or reparative dentin deposition that we think is probably going to be choking the pulp off later. So this is one more reason to think about maybe stimulating artificially to get the reparative dentin is haphazard dentin. Every endodontist will tell you that this sort of thing leads to really weird dentin deposition. It's haphazard dentin deposition sometimes. And this was not even a direct pulp exposure. Imagine if that was a direct exposure, you'd have this thing choking itself off a little sooner. Does anybody have a question about this whole upstream versus downstream insult? Remember, the pulp's being nourished from the apex. So everything that cuts the crown off from the apex could potentially create, a very untoward long-term response of the pulp chamber. Is anybody wondering here, Taras? Anybody got questions, or are we okay? John?
I think we're good.
Dr. Clark, there's one question in regards to matrices, if you want that one, or do you want to wait on it in the end here?
I want that question, but I want Augusto's doing. Is that a frozen picture of Augusto? We may have lost Augusto. Do I still have?
No, I'm here.
Augusto, I want you to. This is the first time you've seen this concept of a downstream versus an upstream insult to the pulp. Just your first impression here. Do we have Nate Lawson on the line too?
No, he had to attend something. Did you make it? Okay, great. There he is.
Let's go back to matrix choice in a minute, but I just wanted, if Dr. Sue Gross has a thought about this whole concept of long-term, how getting, stimulating what we thought reparative dentin was a good thing, that we don't know what we're doing. Like nature has a plan, right? And we think we have a better plan. But in this case, the architecture of reparative dentin is going to eventually choke off the pulp chamber.
David, I'll comment since this is Nate. So this is something I'll be honest, I've never seen this before. I've never seen it presented this way before. And it kind of seems like what you're saying is that if you're doing the traditional way that we've been taught about doing a direct pulp cap, where you have something like calcium hydroxide or calcium silicate, which is causing the odontoblasts to release growth factors to stimulate reparative dentin. We always thought of that as a good thing, because that reparative dentin is forming this layer between the pulp and the outside of the tooth. And to think about it as, not a protective layer, but as something that's suffocating the blood flow, it's a new concept. I mean, theoretically, I guess it makes sense. And I think the other thing that you're pointing out is that it depends on the location of, upstream versus downstream. So that, like you're saying, if you do it around the cervical area is different than if you do it in the incisal area. So I guess what you're saying is that cervical area is worse, because if you do it in the cervical area, it's like, I like that you're choking off the crown of the tooth, the top part of the tooth. I mean, again, that makes sense. And I guess it's saying that if you're getting reparative dentin either in the bottom of a box of a class 2 or at the cervical area of a class 5 is worse than maybe in the incisal edge or at like a pulp horn. And so in some ways that's saying that we've got to be maybe more diligent or more considerate about not doing direct pulp caps if we're going to, do one, let's say a deep class 5 or a deep class 2. To me, I'm following along. It all makes a lot of sense. I'll be honest, it's the first time I've ever heard anything like this, though. I don't know if that's the kind of feedback you're looking for.
Nate, that's exactly what I'm looking for. These are conversations that we haven't had in the past, because we thought that reparative dentin and causing a purposeful irritation of the pulp was a good thing. The deeper question, Nate, this is a conversation that happens on 3 different levels, okay? And you've actually talked about 2 of the 3 levels. The last one is maybe stimulating artificially with chemicals or an insult, maybe stimulating reparative dentin is something that we should actually never do, because we don't know what's going to happen. We know that the tooth has a natural healing process that's 95% successful if we don't expose the pulp. And the closer we get to the pulp, it's essentially a de facto exposure. So there's a lot of good questions. This slide asks more questions than it answers, Nate. And here's the cool thing. I'm old. You and Augusto and Susan Gross, you guys are young. You have the rest of your career to think about this concept about the 20-year survival of the pulp, okay? And maybe we don't know enough about about artificially induced or reparative dentin to think that we're smarter than the body. I mean, how many times over the years have we decided that maybe artificial things are not good? Maybe smoking cigarettes is bad, right? I mean, remember in the old days, they told us smoking, well, you're not. They actually had a tobacco institute that told us that smoking was good for us. Okay. Maybe all these preservatives are, maybe natural is better. So these are 3 different questions. Okay. So anyway, this is a conversation for a different day, but these are the conversations we're going to be having for the next 20 years. I'm so glad you could join, Nate. So, back to matrix choice. So we had a question about matrix choice. Who had that question?
Before that one student asked about, I understand that dentin gets stimulated, but for buccal caries, what would be the suggested approach? Because we do have to do something, right?
Yes. What you need to do, and what we're teaching, I mean, it depends on what the school is going to do, but the modern thinking is we do not want to stimulate artificially to have dentin deposited rapidly, because we're now questioning something that we have believed in for 100 years. We're questioning something we believed in for 100 years. Maybe we don't want to artificially stimulate dentin deposition. What we're talking about is leaving decay and sealing it. So when you have deep class 5 decay, we want to be very careful about not drilling into the pulp, not getting close to the pulp. You want to get a good peripheral seal, and with composite, we can have an infinity edge margin, leave just a thin layer of frank caries over the pulp, figure out where the pulp is, don't hit it, get a good seal at the DEJ, and then do additive dentistry and do an infinity edge, seal the decay, and let the pulp heal naturally. You win the game if the patient calls back the next day and says, I have no pain. If the patient has no pain, you were able to leave enough caries over the sensitive area that the pulp just goes on about its business and the pulp doesn't even know that you intervened. That's a really good indicator that you did well. And here's the funny thing, Nate, 1,000 years ago when you were 2 years old, dentists didn't have anesthetic. This is actually way before you were born, right? When your parents were little kids, right? When your parents were little kids, they had no anesthetic. They drilled on the tooth till it hurt, and then they stopped drilling. Guess what? That was a smart way to go, because when the odontoblast starts screaming, that's when actually we're starting to harm them. So there are practices from dentists in the old days that left decay behind routinely because they would stop drilling when it hurt. And those were incredibly successful cases. It was accidental selective caries retention.
David, can I make another comment? So like, I love this. One thing I've noticed is like, if you go around and talk about selective caries removal to groups of practicing dentists, one of the comments that you'll get, and I'm sure you've gotten this, is, well, if you're leaving bacteria inside of that tooth, if you're leaving affected or even infected or even affected dentin inside of there, you're going to leave some bacteria in there. And the dentist, I'll always get this if I lecture about selective caries removal outside of school, is there's going to be those anaerobic bacteria that are living inside of there, and what's going to keep them from going deeper and deeper into the pulp. And I mean, I think that the argument, right, is that that's the whole importance of doing that seal, is to prevent any kind of nutrient source to any bacteria that's inside of there. I mean, that's the best way that, as I'm trying to explain this, and, the naysayers that would rather have you do complete caries removal. Right. Is that how you would address that similarly? And then also on top of that, then I could say, well, also you could use something like chlorhexidine if that's your.
Nate?
Yeah.
Time out. So did you see the histology slides? Were you there when I showed the histo?
Yeah, I was here.
Okay. I want you to take a look, and I'll give those articles to you, okay? Mm-hmm. What happens is when you leave frank caries like that, you cannot sterilize it because sometimes there's 2 millimeters of frank decay. So putting a little chlorhexidine over that is not going to get internal. Here's what the histology tells us. Once you get a restorative seal, I listed 10 different agents that the odontoblasts are going to perfuse through the immature dentin, into the dentin tubules, into the carious dentin, and over time, that frank caries becomes sterile and hard. So what you are going to do from the outside, Nate, is pales in comparison to what the pulp's going to do from the inside. So you can swish it with bleach or to make yourself feel better, or put chlorhexidine on it. It does not matter because the body is so much more powerful than anything we can try and do from the outside. And think about it. You're going to splash some chlorhexidine for 5 minutes on that selective caries retention. The body is going to sterilize it for the next 20 years, 24 hours a day. Who's going to win that war, right? Mm-hmm. The body's going to win. So look at the histology, look at what the dentin is doing from the inside. So your job is just to let the body heal itself by getting a good restorative seal and leaving that little cushion of frank caries over the pulp horn.
And do you think that's a reason? I mean, so when with the students that are listening to this, when they go out and practice and that they're associating for some doc that says, what are you doing, you crazy person, leaving this in there? What about all those bacteria? I mean, do you think it's a reasonable response to say, I'm sealing it? That's the whole point of why that's why I'm leaving this peripheral seal, and that's what is preventing those bacteria that are in there from, burrowing deeper down into the pulp. I mean,
right. The body has a natural, think about it, the body has a natural response to dealing with caries as it marches in. Let the body heal itself. Let the body heal itself. Just protect it from nourishing that dentin, the caries from the outside. That's all you have to do. So we understand that change is disruptive, but the science is on the side of your students, and the patients want to be comfortable. Nobody wants a root canal. Nobody wants inflammation. Nobody wants something unnatural. Nature and the patient are on your side when you do selective caries retention, and the studies are all on your side, right? Mm-hmm. Don't let the naysayers talk you into bad treatment like I did on that poor little girl. That poor little girl had pain every day for 5 years. Now, I don't feel bad that I made a decision based on old science and I listened to all these old guys, but I do feel bad that she had pain for, 5 years, right?
Mm-hmm.
So, this is a great question and it's a very exciting topic and we're about out of time. So let's go ahead and blast through a couple of slides and then we're going to move. This is awesome. These are all, I really was excited about this topic because the schools need support. And these young bucks, these very progressive professors that are on the panel with us, let me tell you, students, you're so lucky to have these progressive thinkers that are helping to guide your decisions. That you are fortunate. So we're happy to be with you. One thing, chemotherapeutic versus microsurgically. So this was a study done by these folks in Brazil. They actually put wax. They put wax over the pulp instead of calcium hydroxide. So Nate, here's your answer. In this study, they did selective caries retention and put wax over the pulp. And either way, the caries stops, right? And either way, the tooth becomes, the dent becomes sterile. This is a crazy study you can only do in Brazil. This shows you that what you do to that selective frank caries doesn't matter, right? I love this study. Crazy, right? So this is the last thing. 3M's instructions for use for Filtech. This is great. Slightly overfill the cavity to permit extension of composite beyond the cavity margins. I know that this may seem like a little tiny thing. This is everything. Some chemists probably wrote this in the instructions. They knew in the lab 20 years ago that putting the composite past the margin got a good restorative seal. But in dental schools, when you were in dental school, when I was in dental school, Susan, when you were in dental school, if you had composite past the margin, it was flashing. It was the effort. It was a bad thing, right? So the Bioclear method, and one of the reasons that 3M is joined with Bioclear Learning Centers, they understand that the infinity edge with injection overmolding is the heart and soul of really of modern composite dentistry. But just like selective caries retention, the infinity edge just makes sense. But sometimes just because something makes sense doesn't mean that the dental community is going to adopt it right away. So these dental students, you're in this incredibly powerful time of change. You're fighting all the old dragons and all the old demons of traditional GV black dentistry. And every one of these things in the Bioclear method, whether it's additive dentistry, selective caries retention, injection overmolding, compression, modern cavity preparations, we're really excited that we're able to work with your faculty and serve them and help kind of move this method forward. And it's an exciting time for us all to be working together. The community that we have together is, to me, is such a source of joy, and it gets me up in the morning, especially 5:30 in the morning to do a presentation to you folks. All right. So we are out of time. Let's see here. Oh, here's the point. This is the GV Black prep that we were all trained to cut. And this is the prep you cut at Minnesota most of the time and a lot of the other schools. That margin is going to leak no matter what you do. I'm sorry. When you do the Bioclear method and you do injection overmolding with additive dentistry, that insane restorative seal with low C factor allows you to keep caries in the tooth. So let me back up the point. Let me have all the faculty talk about this right now. If this is the kind of margin that we create, is selective caries retention going to work long term? If this is the best I can do, and this is standard of care. That is standard of care in a class 2 right now in a box prep. If that's the best I can do, is selective caries retention going to work? And then we'll wrap it up from here. So let's hear from our panel. Let's put the panel up to main. Can we put the panel up with the stop share?
No, it's not going to work.
No, it's not going to work. It's going to leak from the outside. Absolutely.
And then the body won't be able to heal it, right?
Right.
That patient got caries there for a reason in the first place. They weren't able to keep it clean. And so why do we think that if we're going to put a butt joint on composite that we know that it doesn't marginate, that they're going to be able to keep it clean in the future? It's just not going to happen. And so it doesn't matter whatever we're doing pulpily in the tooth with selective caries retention. If it's going to leak right away, we might as well just go straight to endo.
Dr. Drummond? Nate?
That sort of leakage is got the biofilm still there probably when they did the original prep and restoration, and that means there never was a seal. It's not that it started to leak after a while. It's there never was a seal, and you're screwed from the beginning.
Okay. How do you really feel, John?
Yeah.
Dr. Robles.
I agree with Dr. Solomon. What he was saying is exactly the point. The cares was there. It started at some point and somehow, and now we think like this little preparation is going to take care of the problem. No, I mean, you have to clean the whole area and be able to maintain it clean. So that's a great point.
Mm-hmm. Mm-hmm.
You know, when we have a metal matrix and you're trying to cure through composite, what do you think happens? You look like you're curing from the occlusal surface. You take that metal matrix out and you have a bunch of blood that rushes back in. What do you think is happening in your periphery of your composite there down in your box?
Right.
You're getting blood that contamination in right away. You're not curing all the way down into the metal matrix. It's impossible.
Right.
Just bringing again that concept of the modern extension for prevention. And if you think about where we can get that resin out to, really at no cost, you don't have any biologic cost to bring that bond onto that clean blasted enamel. And all of a sudden, now you've created a really like a bulletproof zone that bacteria really have no chance of getting through, because we know our best bond is to enamel in dentistry. And that's the bond that we trust. So let's use it and create that seal to protect that pulp.
Mm-hmm.
And not have to change our restorations every 6 years.
Perfect. All right. Well, this has been a blast. We have, like I said, this is just the beginning of a long journey that together, and we're making a huge difference. I'll tell you right now, everybody's commenting, even this opportunity for the last month to meet with the schools and for schools to talk to each other and then actually talk to real dentists in the community all at the same time, and manufacturing, and look at the research. This is a community of caring doctors having fun together. And, but we have to have a structure to this. And that's the purpose of the Learning Center is for all the faculty members of the Learning Center to be your servants, and for all the people, 3M and Clinical Research Dental and Bioclear to help integrate this into the schools. I'm looking forward to coming out to Minnesota and launching.
Yes. We'll reschedule. We'll reschedule.
I want to come out and visit McGill. I know you guys don't need me.
David, we need you at McGill too, so we're going to be inviting you. Come.
Great. I hope we get a chance to maybe get invited out to Alabama and hang out down there and have some
Be awesome.
Southern hospitality. So and so I know a lot of the faculty members would love to come along and be part of that. Bring a lot of energy in, because we have to overcome old inertia. So having, fresh bodies in, right?
Nate, wait, okay. Nate, I think I've met Nate then before, right?
Yes, I just sent Sue a private message. Yeah, I've heard a lot about you, but yeah,
Oh
I really
my
put the script together.
Thank you very much for reaching out. Thanks.
All right. So it's a wrap. This has been recorded, and we have, like I said, people that will coordinate, follow up and more. We didn't even get to deep margin acquisition. So we spent all the time on really the selective cares retention. So we do need to have a deep margin acquisition. How do you get down to deep margins? So we probably should have one more presentation. I hate to do it at 5:30 in the morning, but
that's okay.
Do we want to try and do one more presentation about how do we actually get good margins at bone level on posteriors?
Sure.
I'd love that. I think it'd be great.
Yeah.
Is that you, Augusto?
Yes, I think that'd be great.
That would be awesome.
Because if we can't get down there, if we can't get a good restorative seal near the bone level, it ain't going to happen.
It'd be really nice to see that, yes.
Okay. Well, I guess
Same time, same station?
All right, here we go. More coffee. All right. My staff is screaming right now. Okay. Joshua Solomon is dying. He's got to get up to the crack of dawn again. All right. We'll do one more. We'll do one more with the schools. How about that?
Sounds awesome.
Fantastic.
Thank you,
David.
Thanks,
All
Dave.
Thank you very much, Dave.
We'll see you next time.
Thank you.
Great. So we'll set that up.
Bye, everybody. Thank you.